Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very precious tips which may prove very handy in your line of duty. So I welcome you all to part 121 of our pharmacotherapy MCQ series, Measuring in Infectious Diseases. Welcome. And the first question reads, Mr. WTT, a 37-year-old male who abuses IV drugs, presented to your hospital with a past medical history of Streptococcus aeruginosus infective endocarditis, status post-tricuspid valve replacement 2 years ago. He admits to using heroin in the past 7 days. He was admitted with a chief complaint of fevers, chills, rigors for several days, and increased lethargy. Some of his vitals prior to admission included a slight fever, temperature of 38.5 degrees centigrade, a heart rate of 110 beats per minute, a respiratory rate of 12 breaths per minute, and blood cultures were drawn, 2 sets. And vancomycin and cefepime were initiated as empiric therapy. So both samples of the blood cultures turned positive. They grew Staphylococcus aureus, and the susceptibilities are still pending. A TEE was done, and a mobile echo density raising concerns for the presence of a vegetation on his bioprosthetic tricuspid valve was noticed or observed. So my question to you is, which of the following is the correct diagnosis for Mr. WTT basing on the modified Duke's criteria? Is it true that more information is needed to make a diagnosis? Or is it true that this is not a case of endocarditis? Or is it a possible case of endocarditis? Or is it a definite case of endocarditis? I'll give you 10 seconds to choose the correct answer. So this is a definite case of endocarditis, and I'll tell you why. This patient meets 2 major Duke's criteria. Remember, the blood culture is positive for typical microorganisms causing infective endocarditis, and the echocardiogram is positive for IE, infective endocarditis, and thus he qualifies as having definite endocarditis. That makes answer D correct. And the other answers B, C, and A are all incorrect in my opinion. Let's move to the next question, please. And it reads, according to WTT's culture and sensitivity results, MRSA is present. The lab have reported results of the cultures you are waiting for. So my question to you is, how should the clinical team modify Mr. WTT's regimen? Should they stop vancomycin and cefepime and start daptomycin and gentamicin? Or should they continue vancomycin and cefepime and start gentamicin? Or should they continue vancomycin but stop cefepime and start rifampicin and gentamicin? Or should they continue vancomycin but stop cefepime and start rifampicin? I'll give you 10 seconds to choose the correct answer. So answer C is the correct option. We should continue vancomycin and stop cefepime and start rifampicin and gentamicin. I would like to start off by commenting that MRSA prosthetic valve endocarditis should be treated with vancomycin, rifampicin, and gentamicin, which makes our answer C correct and answer D incorrect. I would like to add that cefepime is not required or needed now because an organism has been isolated and thus targeted therapy can be used, which makes answer B incorrect. Then I'd also like to add that daptomycin is an appropriate alternative treatment option for MRSA endocarditis. However, it is broader than necessary, and if used, then gentamicin is not needed, and that makes answer A incorrect. Let's move to the next question. So it's a continuation of the same case. Mr. WTT's blood cultures turned negative after 5 days of antibiotic therapy. The clinical team treats him with appropriate MRSA endocarditis therapy for 14 days, after which he undergoes repeat tricuspid valve replacement. The cultures on his tricuspid valve return negative. On January 10th, blood cultures were 2 of 2 for MRSA. On 11th, they were 2 of 2 MRSA and appropriate therapy was started. On January 13th, the blood cultures were 1 of 2 MRSA. On 14th, the cultures were 2 of 2 MRSA positive. And on 15th, the cultures were 2 of 2 negative. On 24th, the TV replacement surgery took place and TV cultures were negative. So my question to you is, which of the dates listed below would you consider day 1 of therapy with regard to this patient's treatment? Was it be January 25th, January 15th, January 11th, or January 10th? I'll give you 10 seconds to choose the correct answer. January 15th it would be. Now, day 1 of therapy is considered the first day of negative blood culture. So that makes B the correct answer, and answers D and C are incorrect. Now, if the tricuspid valve cultures had been positive, this would be considered day 1 of therapy. However, they were negative in this case. That makes answer A incorrect. Let's move to the next question, please. And it reads, G.M.D, a 78-year-old geriatric patient, lives in a nursing home with a past medical history of hypertension, type 2 diabetes mellitus, prostate cancer, and stage 3 chronic kidney disease. On presenting at the accident and emergency department, he is somnolent and he has had a decreased appetite in the past 7 days. Some of his pertinent vital signs include a temperature of 39, is a bit feverish. There's a leukocytosis. His WBC is 17.2 times 10 power 3 cells per mm cubed, and his serum creatinine is 0.9 milligrams per deciliter. The accident and emergency nurse obtains blood and urine cultures prior to initiating empiric antibiotic therapy with vancomycin and piperacillin tazobactam. And his blood cultures turn positive after 24 hours, and the lab grows Enterococcus faecalis. And this slide shows the susceptibilities. So this bug is susceptible to ampicillin. The MIC is 1. It is susceptible to gentamicin. The MIC is below 500. It's susceptible to streptomycin and also to vancomycin. Now note the vancomycin MIC is 2. So the team performed a TEE whose results were inconclusive. A follow-up TEE was done, and it was positive for a vegetation on his aortic valve. The cardiothoracic surgeon rules out surgery in the case of Mr. G.M.W. now. He has chosen to defer surgery. So my question to you is, which of the regimens listed below would be the most appropriate for Mr. G.M.D's treatment now? Would you choose to treat him with ampicillin plus gentamicin plus rifampicin for 4 weeks? Or would you choose to treat him with vancomycin plus ceftriaxone for 4 weeks? Or would you choose to treat him with ampicillin plus streptomycin for 6 weeks? Or would you settle for ampicillin plus gentamicin for 6 weeks? I'll give you 10 seconds to choose the correct answer. I would settle for ampicillin plus gentamicin for 6 weeks. Now I'd like to start by saying that first-line therapy for native valve E. faecalis infective endocarditis happens to be ampicillin plus gentamicin for 6 weeks, which makes answer D the correct answer. Now, while the organism is susceptible to streptomycin, this agent is not ideal due to lack of clinician familiarity and the limited access of most institutions to streptomycin serum assays. That makes answer C incorrect. Then I would like to add that vancomycin is broader than necessary and does not demonstrate synergy with ceftriaxone, which makes answer B incorrect. Then I would also like to add that rifampicin is not needed for E. faecalis infective endocarditis, which makes answer A incorrect. Let's move to the next question, please. And it reads, Mr. B.W.M., a 69-year-old male patient, presents to your accident and emergency department. He has a past medical history of mitral valve replacement due to severe mitral regurgitation, which was done 120 days ago. He was admitted to a hospital next to his home for sepsis, and the clinical team there initiated vancomycin and piperacillin tazobactam without first drawing blood for culture and sensitivity. A blunder indeed. Bad stewardship. They also performed a TEE due to his history of mitral valve replacement, and it showed a mass on his bioprosthetic mitral valve. They then transferred Mr. BWM to your hospital, which is better equipped and has more specialties for further workup and treatment. Blood cultures from the outside hospital were negative ×2 to date. And this gentleman has no history of any infections. So my question to you is, which of the regimens listed below would be the most appropriate for Mr. BWM's treatment now? Would you choose to treat him with vancomycin plus cefepime plus gentamicin plus rifampicin? Or would you choose to treat him with vancomycin, ertapenem, and rifampicin? Or would you settle for vancomycin plus ampicillin, sulbactam plus gentamicin? Or would you treat him with vancomycin plus cefepime? I'll give you 10 seconds to choose the correct answer. I would opt for vancomycin plus cefepime plus gentamicin plus rifampicin. Remember, patients with prosthetic valve culture negative endocarditis with a valve that was replaced less than a year ago should be covered for staphylococci, enterococci, and aerobic gram-negative bacilli when treating them. I'd like to add that antimicrobials in Alternative A cover all these organisms. Gentamicin is needed for synergistic activities against enterococci, which makes answers D and B incorrect because they don't have any gentamicin. And rifampicin is needed for empiric treatment of Staphylococcus aureus, a prosthetic valve infective endocarditis. And that makes answers D and C incorrect because they do not have any rifampicin in them. Let's move to the next question, please. And it reads, G.M.D, the patient with the native valve E. fecalis infective endocarditis was initiated on ampicillin plus gentamicin in your general medical ward. The medical team or the clinical team plans to discharge him back to the nursing home where he resides. So my question to you is, what monitoring should be done at the nursing home during his therapy? Should it be A, once weekly CBC, twice weekly serum creatinine, monitoring of vestibular toxicity, and gentamicin troughs as needed? Or should it be B, once weekly CBC, twice weekly serum creatinine, monitoring for neurotoxicity, gentamicin troughs as needed? Or should it be C, once weekly serum creatinine, no gentamicin troughs when are needed, given short gentamicin treatment duration? Or would it be D, once weekly CBC and BMP, twice weekly LFTs, no gentamicin troughs needed, given short gentamicin treatment duration? I'll give you 10 seconds to choose the correct answer. So the correct answer would be once weekly CBC, twice weekly serum creatinine, monitoring for vestibular toxicity, and gentamicin troughs as needed. I would like to start by reminding you that gentamicin troughs are necessary given risks of toxicity with elevated trough levels. So that makes answers D and C incorrect because they don't mention any trough level monitoring. In fact, they discourage trough level monitoring. Then I would like to comment that gentamicin is associated with vestibular toxicity, thus monitoring is needed, and that makes answer A correct. And I would like to remind you that gentamicin has not been associated with neurotoxicity, which makes answer B incorrect. Let's move to the next question, please. And it reads, G.M.D. receives ampicillin plus gentamicin for 7 days, which caused an increase in serum creatinine to 1.7 milligrams per deciliter. He experiences a decrease in urine output. He is tolerating his regimen well. So my question to you is, which of the therapeutic modifications listed below would be the most appropriate for Mr. G.M.D. now? Would you choose to stop gentamicin and continue ampicillin alone as monotherapy? Or would you stop ampicillin and gentamicin and start daptomycin as monotherapy? Or would you continue ampicillin and switch gentamicin to streptomycin? Or would you continue ampicillin and switch gentamicin to ceftriaxone? I'll give you 10 seconds to choose the correct answer. So I would choose to continue ampicillin and switch gentamicin to ceftriaxone. Now, based on this gentleman's acute kidney injury, therapy can be switched to ampicillin plus ceftriaxone. Now, an observational study showed this option to be non-inferior to ampicillin plus gentamicin, which makes alternative D the correct one. I would like to add that streptomycin may also cause renal toxicity, which makes alternative C wrong. It's an aminoglycoside, remember, just like gentamicin. Then I would like to add that daptomycin may be effective, but it's broader than necessary and is commonly combined with another synergistic agent for the treatment of enterococcal infective endocarditis. So that makes it an inappropriate choice for this case. And I would like to add that a synergistic agent must be combined with ampicillin, since ampicillin displays bacteriostatic activity against E. faecalis. So that makes alternative A incorrect. Ampicillin alone as monotherapy would be bacteriostatic. It would not be effective against E. faecalis. Let's move to the next question, please. The next question reads, Mrs. S.A.J., a 52-year-old female patient with squamous cell carcinoma, presents to your oncology clinic. She is still able to eat and swallow her medication. She has a past medical history of bipolar disease, type 2 diabetes mellitus, and aortic valve replacement, which was done due to severe aortic stenosis. She is allergic to penicillins, and she developed hives after administration of penicillin. She's also allergic to vancomycin, and we are told she had severe itching when it was last administered. The medical oncologist schedules an appointment for a tongue biopsy in 7 days' time. So my question to you is, would you recommend antibiotic prophylaxis for infective endocarditis in Mrs. S.A.J's case, or would you not? I'll give you 10 seconds to choose the correct answer from the list below. Is the correct answer: blood cultures should be drawn prior to the procedure to determine the need for prophylaxis? Or is it no? Or is it yes, one dose pre-procedure only? Or is it yes, one dose pre-procedure and one dose post-procedure? I'll give you 10 seconds to select one from that list of 4. So the correct answer is C. I would administer one prophylactic dose before the procedure. It is reasonable to give one dose pre-procedure for patients who are at a high risk for complications of endocarditis, going into invasive surgery or procedures such as a biopsy, and that makes answer C the correct answer, and it makes answer B incorrect. Now, a post-procedure dose is not needed, and that makes answer D incorrect. And I would like to add that blood cultures are not needed prior to the procedure, which makes answer A incorrect. Let's move to the next question, please. And it says, which of the following antibiotics would be the most appropriate prophylactic agents in Mr. S.A.J's case? Would it be oral ciprofloxacin, or oral clindamycin, or IV cefalexin, or oral amoxicillin? I'll give you 10 seconds to choose the correct prophylactic antibiotic. So oral clindamycin would be the most appropriate choice, alternative B. I would like to start by reminding you that in a patient with a penicillin allergy who can take oral therapy, oral clindamycin is an appropriate alternative, which makes alternative B correct and alternative D incorrect. The IV route is not preferred, which makes alternative C incorrect, and ciprofloxacin doesn't adequately cover Streptococcus species. So that makes alternative A incorrect as well. Those many words justify why I would settle for clindamycin. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to please remember to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. And I thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in the next videos. Thank you.